Hello, my name is Ali Mohsin Chaudhry, and today I will be presenting a clinical vignette about anticoagulation management in a patient with intracerebral hemorrhage and a mechanical mitral heart valve. Valvular heart disease is common in the United States, and its incidence increases with age at an estimated prevalence of 2.5%. Definitive treatment includes transcatheter or surgical valve replacement with either mechanical heart valves or bioprosthetic valves. Management of patients with mechanical heart valve who require long-term oral anticoagulation and who present with intraparenchymal hemorrhage is a therapeutic conundrum that requires physicians to be mindful of when to restart therapy due to the risk of worsening bleeding, but also be aware that the risk of thromboembolic consequences in the scenario of prolonged discontinuation of therapy could be severe. In regard to the appropriate timeline for safe resumption, guidelines are silent and data is limited to case reports and series due to the acuteness of the complication. We describe a case of a 77-year-old male with a past medical history of hypertension, hyperlipidemia, gout, transient ischemic attacks, paroxysmal atrial fibrillation, as well as a past surgical history of open heart mitral valve replacement with triple bypass surgery 16 years ago, requiring long-term oral anticoagulation with Coumadin. We presented to the emergency department with worsening expressive aphasia that began 2 days prior. Physical exam revealed a well-developed male in no acute distress, alert and oriented to time, place, and person with mild dysarthria and fluent aphasia, with no motor or sensory deficits. GCS was 15 and NIH stroke scale was 2. Initial vital signs and laboratory blood work were remarkable for hypertension, with a blood pressure 152 over 88, hemoglobin was 12.8, platelets 143, INR 3.87, PT 44.7, PTT was 51.2. CT revealed an acute intraparenchymal hemorrhage in the frontal parietal region. The patient was given vitamin K, fresh frozen plasma for anticoagulation, reversed and was admitted to the ICU for close monitoring and frequent neurochecks. His blood pressure was strictly controlled with a goal of systolic blood pressure between 100 and 140, and oral anticoagulation was held. MRI was obtained, revealing left posterior temporal angular gyrus, acute intraparenchymal hematoma with minimal edema, minimal compression of the lateral ventricles, and no midline shift or herniation. Patient's intraparenchymal hemorrhage remained stable with no progression and no neurological change. Cardiology and neurosurgery were consulted regarding timing for therapy resumption. Discussion between subspecialties were held, and after close considerations of risk factors for thrombosis and previous TIA, it was recommended to hold anticoagulation for an estimated time of 2 weeks, with the following goal INR of 2.5 to 3.5. Patient's clinical status remained stable and was discharged to follow up with PCP and resumed Coumadin 2 weeks after stopping. On follow-up, INR day 4 resuming warfarin was found to be 1.2. 3 days later was found to be 1.5, due to which patient's warfarin dosage was increased and found to be in the therapeutic range between 2.5 to 3.5 on the 26th day since holding oral anticoagulation. And on follow-up, 84 days later, with new CT, no hemorrhagic changes were noticed and the patient's aphasia had improved. The mainstream in management is to reverse the effects of oral anticoagulation medications, such as in our patient receiving warfarin for mitral mechanical heart valve. This can be achieved with vitamin K infusion and prothrombin complex concentrate. Warfarin should be stopped on clinical suspicion of intracranial hemorrhage, and vitamin K and prothrombin complex concentrate should be infused as soon as the diagnosis is confirmed. Given the observational nature of different studies regarding anticoagulation resumption after intraparenchymal hemorrhage, there is uncertainty of the correct timing of when to restart. The resumption does not increase the risk of recurrent intraparenchymal hemorrhage and can also reduce the risk of all-cause mortality. The cessation, however, exposes patients to significantly higher risk of thromboembolism, which could be reduced by resumption. The decision for both early, that is less than 2 weeks, and late, that is greater than 4 weeks resumption should be reached only after careful assessment of risk for intracerebral hemorrhage recurrence and thromboembolism. In this specific case, given the patient's mitral valve involvement in atrial fibrillation, there is an increased risk of thrombosis of greater than 10% over the course of 1 year without anticoagulation. Therefore, the decision between interdisciplinary teams of neurosurgery and cardiology was to resume the warfarin in 2 weeks after the occurrence. There is limited data and guidelines on when to restart oral anticoagulation to prevent risk of thrombotic complications in patients with mechanical heart valves. Here, oral anticoagulation was started in 2 weeks due to the greater risk of thrombotic complications in the setting of a mitral valve. Though therapeutic INR of between 2.5 to 3.5 was seen after day 26 of discontinuation, further studies are required to better understand safe periods for holding and restarting oral anticoagulation in these patients. Thank you.